Good afternoon. My name is Maria Rodriguez. I am Professor of Medicine, Infectious Diseases at Baylor College of Medicine and the Chief for the Infectious Diseases section at the Michael E. DeBakey VA Medical Center. I'm originally from Venezuela. I did my internal medicine training in Venezuela and my infectious diseases training here at Baylor. And this is my pleasure today to moderate this session. Our session is entitled COVID and Inflammation in the Elderly. Welcome attendees and physicians from Latin America, Middle East, and the United States. As part of our mission to promote medical knowledge through education programs, the International Center at Baylor St. Luke's in Houston, Texas, in collaboration with Baylor College of Medicine, is honored to host our 7th International Virtual Roundtable to our network of physicians, medical societies, and international medical community. As said before, our topic is COVID and inflammation in the elderly. First, we will have the lecture presentation by our speaker, Dr. Gustavo Rivero. Throughout the presentation, please feel free to submit questions via the chat box located in the bottom right of your screen. Post-presentation, we will open virtual roundtable with questions, comments, and observations from our panelists and from the audience. Before introducing our speaker for this afternoon, I would like to welcome our Latin America panelists who will join us after the presentation with their opinion. So let's welcome first Dr. Álvaro Dávalos from Ecuador. Dr. Dávalos graduated from the Faculty of Medicine of the Central University of Ecuador in 1982 with postgraduate training in the Faculty of Medicine of the University of Miami, School of Tropical Medicine and Hygiene, Faculty of Medicine, University of London, School of Medicine at the University from Warwick. He's currently director in Ecuador of IAMAT, which stands for the Organization of Medical Assistance to Travelers, based in Guelph, Canada, which has been operating in Quito since 1992. He was appointed as the doctor of the Royal Dutch Aviation Company, KLM, in 2014, and of the Air France company in 2019. He is an associate physician of Hospital Metropolitano in Quito since 2000, where he has served as president of the Infection Control Committee and head of the Infectology Service. He is also an associate physician at the Hospital de los Valles since 2010 in the areas of infectious diseases and tropical medicine. Welcome, Dr. Dávalos. Happy to have you here. Dr. Jorge de los Rios from Peru. Dr. de los Rios is a pulmonologist with healthcare experience in the public and private practice. He served as head of the pneumonology service at Hospital María Auxiliadora in their Center of Excellence in the management of tuberculosis and respiratory diseases. He currently works at Clínica San Felipe, one of the most prestigious private clinics in Lima, where he's part of the COVID-19 committee. Dr. de los Rios has served as the coordinator of pneumonology residents at Hospital María Auxiliadora and president of the pneumonology committee of the Faculty of Medicine at University San Martín de Porres. In addition to being a key lecturer in national and international congresses and a reviewer of scientific medical journals, Dr. de los Rios is a principal investigator in phase 2, 3, and 4 clinical trials in pneumonology. Welcome, Dr. de los Rios. Happy to have you in this session. And our third panelist, Dr. Roberto Miranda Ackerman from Mexico. Dr. Miranda Ackerman is staff physician in internal medicine, hospitalist and outpatient clinic, and critical care medicine division at Hospital San Javier in Guadalajara, Mexico, since 2011. He's assistant professor in San Javier Hospital San Javier Hospital Clinical Clerkship Program in Internal Medicine and the Critical Care Medicine Rotations, Autonomous University of Guadalajara, since 2017. He is a board member of the State of Jalisco College of Critical Care Medicine since 2017 and also a leader member of the Ethics and End of Life in Critical Care section of the Mexican National College of Critical Care Medicine since 2018. Welcome, Dr. Ackerman. Thank you, doctors, for your time. We will be connecting with you right after the lecture to obtain your observations and points of view. Now, it is a privilege to introduce our speaker for tonight, Dr. Gustavo Rivero. Dr. Gustavo Rivero is an assistant professor in the Department of Internal Medicine, section of Hematology and Oncology at Baylor College of Medicine in Houston, Texas. Dr. Rivero is a translational scientist who treats acute myelogenous leukemia and myelodysplastic syndrome at Baylor St. Luke's Medical Center. He is co-director of high-risk hematology clinic at the Michael E. DeBakey VA Medical Center, the place where we spend most of our time together here. His work concentrates in identifying targets for deregulated innate immunity in myelodysplasia and acute myelogenous leukemia. He is part of adult working group for hematologic malignancies at Baylor College of Medicine and also part of advisory board for European Leukemia Network. Welcome, Dr. Rivero.
Thank you, Maria. So, all right, so I wanted to thank Baylor International for this opportunity to talk about COVID-19 and especially concentrating our effort in trying to identify and brainstorm our panelists and our moderator and how this very vulnerable population should be treated. So the data that I want to present today is prelim data. The data have been submitted to the American Society of Hematology meeting in 2020. It's just a data to initiate, to trigger a discussion, a very nice discussion between the panelists, moderator, and myself. So that being said, I'm going to highlight a few objectives. And the very first one, it will be to identify known factors leading to poor outcome among elderly patients diagnosed with COVID-19. The second objective, to improve the ability to predict life-threatening COVID-19 infection in elderly patients based on complete blood count modification. As I mentioned before, the two above objectives will serve to initiate questions, discussion from our panelists to better understand the management of elderly patients with COVID-19. I want to present a preview. We are going to initiate the presentation with a case presentation. Then quickly, we're going to move into the epidemiology of COVID-19 infection. Then we're going to move into the work that we're currently doing since March 2020 in order to establish predictors for life-threatening COVID-19 infection in patients who are elderly. So we are going to present prelim data and then results and conclusion from the study. So as per today, August the 6th, 2020, at 4:30 p.m., 19 million, more than 9 million cases have been diagnosed around the world. So the number of deaths is dramatic, 7,400,000 deaths. And among them, among those 19 million people who are infected with a disease, with a condition, almost 12 million have recovered. I wanted to highlight in this table the situation in the United States, right? As you can see, the total cases, as per today, 5 million, more than 5 million cases, added 40,000 cases today, and for a total of 162,000 deaths today. So followed by Brazil with 2 million cases, 10,000 new cases, and 97,000 deaths. Then we have a panelist coming from Mexico. We have panelists coming from Peru and Ecuador, and the situation is relevant. And with 456,000 and new cases.
Oh, so sorry. Are you sharing your screen?
I am, yes.
No, you're not. You want to share it?
Oh, I'm so sorry. I apologize. The screen was. Okay, so I think we went through this objective, the first one, the second one, and then the major consolidation, that is to initiate question and discussion between the panelists and understand the management of elderly patients with COVID-19. Then we went through this, the preview, which is a case presentation, the epidemiology of the disease, and then move into the a study that we're performing since March 2020 to identify predictors of COVID-19 infection in elderly patients based on CBC, complete blood count modification. So then we can move straight to where we were. I apologize that the screen was not shared, but I was mentioning that since March to now, August 6, 2020, 40:30 p.m., so more than 714,000 deaths around the world. We were emphasizing and highlighting the number of deaths in the United States. So 40,000 cases in the United States with a total of 162,000 cases that represent the death in our country. Then followed by Brazil, and then those countries that represent the panelists that we have today, Mexico, Peru, and Ecuador, with 49,000, 20,000, and 5,000 deaths. So this is important, and this information represent not only a significant, humanitarian crisis, but as well a significant burden, economic burden for the world. So we are going to move very quick into the case. We had recently a 79-year-old male who was admitted with dry cough, diarrhea for 3 days. Upon admission, his oxygen saturation was 89% at room air, heart rate 110, and the temperature 38.9. So day one, you can see the CBC, a white count total, 10,800, ANC 8.2 thousand, 0.33, meaning 333, absolute lymphocyte count, and absolute monocyte count of 280. PCR for COVID-19 was detected positive. As you can see, the patient presented with an elevated creatinine, which is very typical for this situation. Day two, the saturation continued to drop despite oxygen supplementation, and mechanical ventilation was initiated. Soon after, the blood pressure dropped. As you can see, 60/40, and the patient required vasopressor support. So one important feature is that the patient complained of arm pain right before his intubation, and a Doppler ultrasound showed a deep vein thrombosis in his arm and bilateral lower extremity. Low molecular weight heparin, 1 milligram per kg every 12 hours was initiated.
Gustavo, we're not.
Yes, I am so sorry. I was in the other slide. So, and then by day 4, a diffuse rash was noted. Blood cultures were positive for a gram-negative rat. You can see down here, bilateral pneumonia detected by CT scan of the chest, and connected totally with the degree of hypoxemia and respiratory failure that the patient was exhibiting. So in summary, according to the World Health Organization and Chinese classification, the clinical severity score detected essentially showed that the patient was a life-threatening condition associated with COVID infection. By the WHO classification and Chinese classification, cases are divided between 3 categories: mild, severe, and life-threatening. And you can see here that the mild cases are characterized by mild pneumonia, mild symptoms. However, severe cases are associated with dyspnea, hypoxia, and an involvement of the lung by 50%. It's very important for the description and the following slide that life-threatening disease is characterized by the necessity of mechanical ventilation and vasopressors. So what is important in the United States and around the world is COVID-19 has become the 3rd leading cause of death among the elderly. So our population in the United States and around the world, with all the advances in science, had increasingly become older. And it is extremely important that, highlight that right behind cardiovascular disease and cancer, COVID-19 has become the 3rd leading cause of death. So disease pathogenesis is, I like to divide this in the following fashion. They are viral-dependent mechanisms and host-dependent mechanisms that intervene in the pathogenesis of the disease. As is very well known, COVID-19 utilized the cognate receptor ACE2 to internalize and induce replication inside the infected cells. So the propagation of acute infection is followed by a secondary stage, which is characterized by hyperinflammation and cytokine storm, and mobilization and recruitment of innate immunity cells into the lung to induce respiratory insufficiency. It's not only the lung, but significant amount of organs involved in the pathogenesis of the disease, with a very heterogeneous presentation characterized by renal involvement, liver involvement, even neurologic complication. What is extremely important about this slide are those host-dependent factors that are very heterogeneous. It might be differentially expressed among individuals, and is characterized by degree of involvement, respiratory involvement, coagulopathy, risk for thrombosis, and then magnitude differentially expressed of organ dysfunction among the organs that I already listed. So this is a study published in British Medical Journal, as you can see here. So the median age for presentation of the disease was 62, and there is a dose-dependent incidence of the disease that exponentially goes higher with age. However, I think it's extremely important to highlight that the median age for death was 68, and then as you can see here, the proportion of the increased proportionally as the age increased. As you get granular with the article, it was very important to detect, and this is back in March, February, that most of the cases were clustering male sex, and extremely important to highlight the comorbidities that have been very well known to be associated with fatal outcome in COVID-19, including cardiovascular disease, hypertension, and chronic pulmonary disease. As you get granular with this article, you can notice that in patients who exhibit death, fatal outcome, the proportion of white count was elevated more than those people who were surviving. And then at the same way, in the same fashion, neutrophil count increased higher, proportionally higher in patients who have a fatal outcome. And then a very well-known factor, which is associated with low lymphocyte count, it was mostly observed among those patients exhibiting death. So in conclusion, high white count, high neutrophil count, and potentially a low lymphocyte count representing a hematopoiesis signature, especially for those patients exhibiting fatal outcome. In summary, the previous article, significant number of deaths occur in subgroup of patients older than 60 years. A high proportion of leukocytes and neutrophil was associated with poor outcome. So this slide and cartoon, let me walk you through this, highlight those reasons that might explain, those causes that might explain fatal outcome in elderly patients. Not only that, a potential reason for a high white count. So it's very well known for among hematologists and physicians that obesity, diabetes, and smoking increase the number of leukocytes. However, it's likely that aging might localize like a central potential factor that might endode the potential for fatal outcome in COVID. So there is a horizon. You can see the horizon is an age more than 60, where most of the cases, fatal cases, are located. So we're going to use COVID-19 as a potential stressors, and then we are going to keep in mind those known factors, obesity, diabetes, cardiovascular disease, orbiting around a potential central core risk factor that might be connected with aging in patients who exhibit fatal outcome after infection with COVID-19. So in the recent years, immunosenescent, inflammatory aging, and other potential factors that might increase inflammatory cytokine have been important in science, especially the role of clonal hematopoiesis. We are going to emphasize this a little bit because it represents a significant background in the work that we have been doing since March. So a little bit about aging hematopoiesis. This is a canonical and hierarchical model, classical model that explains how effectors of immunity are created and all the fate and the disposition repertoire of genes that are needed to be activated to create neutrophils, eosinophils, monocytes, and lymphoid cells. What is known about aging hematopoiesis is a myeloid skewing. It means all these cells that are normally associated with myeloid specification, they get expanded and the lymphoid compartment get constricted. This is a pattern, is a very classical view of aging hematopoiesis. The factors that lead to this modification are largely unknown, but we suspect that potentially those mutations that might expand hematopoietic stem cell compartment might in a similar way expand the myeloid compartment and constrict the lymphoid compartment. So I want to remind you, these are the factors of innate immunity. So this is the view that explains in a prelim fashion how clonal hematopoiesis might happen. This is hematopoietic stem cell progenitor at the DNA level. Mutations might occur, and these mutations occur in a frequency that is normally less than 2%. The mutations are associated normally with a low-grade state of inflammation that is characterized by increase in CRP, C-reactive protein, and IL-6. It's likely that this skewing in aging hematopoiesis might signify, it might predispose, it might prime hematopoiesis to have, at least in part, a fatal outcome in COVID-19. That was our original hypothesis. So little mutations happening in very low frequency, induce low-grade inflammation, induce MDS and acute myelogenous leukemia only in 0.5% of the patients per year, but in reality predispose dramatically to a stroke and heart attacks. So clonal hematopoiesis of undetermined prognosis, as you can see here, increase with aging, achieve almost 30% as we achieve 100 years. And then it's normally observed in very low frequencies. It can happen in age less than 40. As you can see, a cutoff of 70 years might be associated with an incidence of 15%. What are those mutations? They are myeloid-specific mutations, DNMT3A, TEC2, and AXSL1. So they exacerbate coronary artery disease. And an important feature is that they can happen in 2% of the patients who exhibit a myocardial infarction age less than 50. So the haploinsufficiency mice in which a mutation can be induced in 10% of total marrow cells, induce very accelerated atherosclerosis. This is a cross-sectional cut of an artery. You can see that the TEC2 deficient mice increased by almost, in 17 weeks, almost 50% the size of the plaque. One important feature is that the monocytes, they might exhibit IL-1 beta upregulation and IL-6 upregulation, which are two dominant cytokines observed in COVID-19 infection. The apheresis and segregation of monocyte, you can see here in this graph, they upregulate IL-1 beta in a proportion that is statistically significant as compared to those wild type TEC2 monocytes. We wonder whether complete blood count, including absolute neutrophil, monocyte, and lymphocyte count modification predicted the severity of elderly patients diagnosed with COVID-19. Our main hypothesis was that in elderly patients, leukocytosis is an independent risk factor for adverse outcome in patients diagnosed with COVID-19. So as a prelim data intended to demonstrate that age is an adverse effect in mortality for those patients, we reconfirm based on 119 patients that the median age for infection was 60.7 years, and there was a dose-dependent effect that is directly proportional to aging. It goes from 22 to 49, 0%, to 27.2 in those patients aged more than 70. The mortality, intrahospital mortality for our cohort, it was 19.3. So this is a view, and this is a prospective view for week 1, week 2, and week 3 for white count, absolute neutrophil count, absolute monocyte count, and absolute lymphocyte count. As you can see here, the blue line represent the cohort of patients aged 22 to 49, orange 50 to 69, and red more than 70. You can observe that the white count is high and remained high over week 1 to week 3. The absolute neutrophil count had about the same behavior. And then different from white count, AMC, absolute monocyte count, it was lower at the time of diagnosis than those patients aged 22 to 49. A similar situation was observed for absolute lymphocyte count. So what we learned from this aggregation of data was that potentially ANC, AMC, and ALC had a different behavior associated with aging. Then we decided to segregate those patients aged more than 60, calculated the median for this population being 70. And you can observe for those patients aged less than 70 and more than 70, a differential expression for white count neutrophils, potentially a clinical trend for absolute monocyte count, and inflammatory markers-wise, a CRP normally elevated, 18 versus 13% versus 13.5 in those patients aged more than 70. So I want to highlight that the BMI, it was similar for the two subgroups, aged less than 70 and more than 70. I want to remind you, BMI, obesity is an important risk factor for adverse outcome in COVID. So here we have a test. The test represents those patients exhibiting life-threatening disease by the WHO Chinese classification versus those patients without life-threatening disease. It means those patients who needed mechanical ventilation and vasopressors versus those patients who didn't need vasopressor or mechanical ventilation. We have an absolute intra-hospital mortality rate of 19.3% for those patients aged more than 70 versus 8.6 for those patients less than 60. And then here is the initial effort to initiate a hematopoiesis signature in patients exhibiting life-threatening disease. As you can see, neutrophil count was dramatically and significantly different from when you compare patients with life-threatening disease versus those patients without. The absolute monocyte count was lower, statistically significant, and the situation for absolute lymphocyte count was similar to absolute monocyte count. We examined the same signature among patients who were younger than 60 years, and we observed only the typical neutrophilia that normally associated with CXCL8 upregulation after the infection, but the situation for absolute monocyte count and absolute lymphocyte count was totally different. So they were equal between people with life-threatening and without life-threatening infection. So conclusion is that potentially there is a differential expression for absolute neutrophil, monocyte, and lymphocyte count among patients who are aged more than 60. So here we have a visualization of week 1. And during week 1, absolute monocyte count, it was statistically significant. And then immediately after, there is a recovery phase. This striking difference in absolute monocyte count we suspect might be associated with a relocalization of peripheral blood monocyte into the lung, which is a pathogenic mechanistic link that have been described. Most of those BLL, bronchoalveolar lavage, recovered monocytes, they will be IL-1 beta skewed. I want to remind you that TEC2 deficient mice produce IL-1 beta. So the second graph here, as you can see, absolute lymphocyte count, it was lower, statistically lower during week 1 and remain over time low. This is all life-threatening disease. Again, visualization, you can see how a correlation between absolute monocyte count and absolute lymphocyte count highlight a constricted compartment versus those patients without life-threatening disease. The compartment is more expanded. So contraction versus expansion. So it was an important feature that we could see only under visualization. So the second is an unsupervised cluster analysis. And here what we do with a principal component analysis, segregate subgroup of patients with and without potentially life-threatening disease. You can see by using white absolute neutrophil count, monocyte count, and lymphocyte count, we can segregate almost 75% of those patients with life-threatening disease. So we are going to summarize high ANC at a cutoff of 5.8, meaning 5,800, provide a sensitivity of 73.6% sensitivity for detecting potentially life-threatening disease, lower AMC with a cutoff of 222 cells, a sensitivity of 76.3, and absolute lymphocyte count 666, 81.6% sensitivity. We are going to centralize, we are going to focus on absolute neutrophil count as a factor 1, absolute monocyte count as a factor 2, and a factor 3, representing absolute lymphocyte count. When we find the 3 factors, meaning 3 over 3, we were able to detect life-threatening disease in 100% of the cases versus 0%. If we have 2 or 3 factors, we were able to detect life-threatening disease, meaning requirement for mechanical ventilation or vasopressor or in 80.95% of the cases versus 19.05%. You had a p-value 0.03 for the 3 over 3 factors versus 0.02 for 2 or 3 factors. There are caveats and limitations, especially connected with our study. The data need to be externally validated. This is extremely important. Probably early onset steroid might have skewed our result. These are caveat limitations that we need to try to overcome. Future direction, we're trying to procure funding for next generation sequencing to examine all those specific myeloid-specific mutations in elderly patients with and without life-threatening hematopoietic signature. I want to acknowledge my 2 postdocs, Jesus Romero and Jorge Marcini, for all the cooperation and hard work that they had during these past 4 months, collecting data at Baylor St. Luke Medical Center. This work was submitted to the American Society of Hematology meeting for presentation in 2020. And we expect that his work is received and welcomed. I want to go back to our patients. Our 79 years old guy who was admitted with respiratory failure necessitating mechanical intubation. I want to summarize the management for him. Ventilatory support and hemodynamic support was provided. Broad spectrum antibiotics given positive blood culture for a gram-negative rot. Dexamethasone per the recovery trial was given very reassuring data published in New England Journal about 15 days ago, and Lovenox 1 milligram per kg given every 12 hours for treatment of his bilateral lower extremity DVT. That being said, COVID-19 is an inflammatory disease, especially in the elderly, with a significant differential impact that encompasses neurologic manifestations, thrombosis, cardiac manifestation, carditis, heart attacks, and then very likely, potentially, almost every single organ. Infections representing a big bulk of the complicating factors that associate with inflammation to compound a high rate for fatality. So, with that being said, we want to brainstorm our panelists, and I'm going to give the word to Maria Rodriguez, who is our moderator. Thank you very much.
Thank you very much, Gustavo. Very intriguing study and results. And really, I think from the practical standpoint, to have what you're calling your signature with just 3 parameters that can be easily obtained in any patient on admission and be followed up. So let me start with our panelists. We would like to proceed now to open our virtual roundtable with observations and comments from the 3 of our panelists. So I'm going to start with Dr. Davalos in Ecuador. Dr. Davalos, do you have any comments on the presentation and on your experience and how you link what you have learned possibly today with your patients? Hey, Dr. Davalos, you need to unmute yourself. Can you unmute yourself, please?
Thanks for the wonderful lecture, Dr. Rivero. And I think that reminds us of us doing runs on every morning and seeing those changing numbers in our laboratory information. But basically, the scary thing about that is the combination of all those variables that diminish or put our patients in a severe risk of death as we explore more in depth the variations with the pathophysiology of SARS-CoV-19 mortality in the elderly. I just want to mention that in the first slides, really, it's a reminder also of what was published by Williamson in the Nature paper on the 1st of July, where the databases in the British National Health System compiled nearly 17 million people, and they tried to segregate for risk factors and mortality in the elderly. And certainly it's quite agreeable with all the data that Dr. Rivero has presented us in this wonderful presentation. And the things that I need to stress is that even though we are more scientifically inclined to analyze this signature, what we see in reality is that all the comorbidities, the older age, being or having a higher mass index or body mass index, having comorbidities like cardiovascular, renal, hepatic, and also diabetic, and previous medical history of injuries into the patient system, put us to think what is our main concentration or focus when we discuss a case like the one you presented us in real life. In our experience in our intensive care unit or our ward in Quito, what we're seeing more scary finding, the most scary finding that we're seeing now is that our elderly patients have a higher than 29% mortality, and that they all die because of coagulation disorders, spontaneous bleeding. So my first question to Dr. Rivero is that what is the pathophysiological correlation between coagulation disorders, spontaneous hemorrhagic disorders, and prophylactic anticoagulation that is included in most of our treatment plans?
Mm-hmm. So I think it's important from the pathogenic standpoint to, somehow put the patient in context. Number one is, whether or not the patient who is being admitted to the ICU is an obese patient, meaning a weight more than 120 kgs and a BMI more than 40, versus those patients less than 120, BMI less than 40. The second point that is especially important from evaluation of coagulopathy, and especially TBE, thromboembolic complication, is the fact that these patients are behaving like ARDS-like disease. They are extremely sick. Thromboinflammation might be happening. There is necrosis. There are many factors that are being, highlighted for this condition. And it's very specific. We were reviewing today the CHESS, International Society of Thrombosis, and the American Society of Hematology recommendation is that everybody should have some form of low molecular weight heparin thromboprophylaxis. For those patients who are obese that are in that setting, let's say mechanical ventilation in the ICU, the thromboprophylaxis with 40 milligrams only daily seems not to be sufficient. And the recommendation is that potentially those patients should be treated with 40 milligrams BID twice a day rather than once a day. So this is changes that are happening on daily basis, and we have recommendations being modified almost on a daily basis. So in our cohort, we have right now 250 patients. We have examined, as I mentioned before, 119 patients with COVID. And I can say DIC as the other side of the spectrum of complications represent almost like 0.5% of the patient. And Maria can input here. I mean, she has seen a large number of patients in the Veterans Affairs Medical Center, but in our database, it's about 0.1% of the patients. Maria, you have something to say about that? Maria, you have to unmute yourself.
We have not systematically reviewed data, but from data has been published and presented from other series, it does seem that the bleeding complications on patients on anticoagulation, they're not much higher than non-COVID patients in similar situation. So they have to be taken into context. It's certainly a risk, but there doesn't seem to be a very high risk. So anticoagulation should be used when needed. And of course, bleeding complications need to be watched for. It should not be the reason not to give the appropriate anticoagulation.
I guess in line with that is the magnitude of patients that we see with acute renal failure. And I want to remind you that potentially all that molecular weight heparin is excreted almost 90% through the kidneys, and the patient might have overexposure to the medication. So if that is the case, we have a full recommendation for unfractionated heparin rather than low molecular weight heparin. Any other comment from Guadalajara and Peru?
Yeah, so so we can continue with Dr. Ackerman. Do you want to give us your comments? I know
Hi, guys.
you were not present at the beginning, but if you can comment on your general experience of the portion that you could have heard about prior comments.
Yes, well, thank you very much, and sorry for being tardy. No more in line of questioning. Just if this signal would be confirmed in real life, what decisions would we make differently? Or what would be the algorithm, or maybe the prognostic value that we could inform the family, different from what we currently know, which is the age bracket and the poor prognosis in critically ill patients. So you had a real patient, and I'm sorry I couldn't see the beginning, but with your work, what would you say in real life, and how would you manage these signals, these statistical signals?
So I think what is relevant and important to say, we shouldn't take this as a standard of therapy or a standard of care, result. Remember, this hematopoietic signature need to be validated.
Yeah.
And if that is externally validated and adjusted for those factors that I mentioned, whether or not the patient received steroid at the time of diagnosis, that might have a skew bias, our hematopoietic signature, then what we can envision is that potentially you can segregate a subgroup that potentially can benefit from novel anti-inflammatory therapy. Let's say you can predict that potentially the patient is going to require mechanical ventilation or vasopressor. Can those patients more earlier can be intervened, providing dexamethasone at an earlier time point? Could those patients benefit from any novel anti-inflammatory therapy that we are observing in development right now?
Great, understood. So we'll wait and see, and see how that work develops, right?
Right. So,
sorry. Dr. De Los Rios, if you want to comment or share your experience in your particular place, or any other comments you have about COVID and inflammation in the elderly.
I was to make a question in real time with real cases. I think that it's very difficult to differentiate the presence of thrombosis in one patient with critical COVID. Radiologic or tomographic imaging can orientate. You know, if you see ground glass aspect in the tomography, the scan, completely distributed image of ground glass, maybe the patients comport with a high risk for thrombosis, or maybe patient has mechanisms of thrombosis that can explain that critical situation. And when you see patients with alveolar consolidations in the CT scan, maybe patients' behavior of the COVID of this critical COVID is like ARDS, no, acute respiratory syndrome, no. But in real cases, when the patient is not going, has a not good clinical course, it's very difficult to differentiate if patient is developing thrombosis. And the recommendation for treatment with anticoagulation, total anticoagulation, or prophylactic anticoagulation is difficult to decide in this moment.
I guess.
How do you differentiate this?
I want to make a very quick comment. I'm not pretending to be a pulmonologist. I'm not any close to an intensivist, but I am a hematologist and oncologist by training. But some opportunity that I had in my own personal experience and by looking at those patients in our database, I think most of the difficulties that a physician might face is exactly what you said. I mean, your clinical threshold have been diminished dramatically. To detect modifications in the circumference of the arms and legs, that would be easier. If the leg is getting bigger and then you have a Doppler very quick and you detect a DVT and the patient is worsening, presenting with worsening hypoxemia, shunting, then you can predict potentially the patient have a PE. But what about those patients who have a CTA many times done and they continue to have a shunt? I mean, they continue to be hypoxemic. Is that ARDS age versus L, where potentially ARDS is developing in the context of dramatic shunting from alveolo-capillary edema and extravasation of monocyte neutrophils into the alveoli? We don't know. I think what we need to follow are the guidelines. I think there is general consensus that for those patients who doesn't have evidence, at least macroscopic evidence of pulmonary embolism, they should be treated with 40 milligrams of Lovenox. If the patient is a BMI more than 40, weight more than 120, the dose should be adjusted to 40 milligrams BID every 12 hours. And then continue to work in trying to, procure a macroscopic diagnosis coming from Doppler ultrasound or CTA. I totally understand not every single center will have the ability to perform a CTA. Then I will encourage, to continue to use those prognostic score systems such as Wells score. So we have many clinical tools that might predict the presence of pulmonary embolism. I don't know if anybody else in the panel of physicians has something else to say.
The other tool that has been proposed is to use the D-dimer levels, but we really don't know what would be the threshold that should be used to decide when more intense anticoagulation may be needed. And some people have proposed a threshold of more than 1,000 to more than 2,000. But really it's unknown. It's really a gradient type alterations in the coagulation cascade, and when is the right time to intervene with higher dose anticoagulation is not known. Some people propose what they call mid full anticoagulation, so a 50% full anticoagulation. So a little bit more than the prophylactic, but less than the full anticoagulation. I don't think anybody knows the answer, but there's plenty of randomized clinical trials looking at this question. And in the meantime, most societies recommend the usual prophylactic dose and anticoagulation only when there's full anticoagulation, when there's a DVT, and wait for results. That's as much as I can say for now. Any other of the panelists wants to comment on the anticoagulation question? Dr. Davalos or Dr. Ackerman?
I will just like to follow up on the pathophysiology of why our elderly population dies or is more susceptible to fatal outcome in COVID, in severe COVID. So what Dr. Rivero was saying is that a low ANC, low AMC, low ALC brings us to 100% mortality. What about the other the other cell components like platelets, and what is the issue with coagulation, platelets, factor 9, three factors that you've mentioned? Because those three changes might interact at the beginning or at the end, and what is the clinical importance of them? Should we transfuse platelets? Should we start antibiotics immediately if we scored two of the three factors or only one of the three? In clinical grounds, what is your best advice? I know that there are listed protocols on what should be done, but there are something like 178 protocols to treat severe COVID disease. Dr. Rivero.
So I want to restate that the hematopoietic signature need validation. It's not by any means a standard of care, and I think it's important to leave a message to all the audience that this is in very prelim research stage, and it requires validation. However, as a future direction and what we can envision, as I mentioned before, is that potentially in the elderly might segregate as a group of patients that develop life-threatening disease. So I think your questions are very interesting. As you can remember in the table that I showed, those patients who were above the median, for those patients who were everybody older than 60 years, the CRP was 18 versus 13 for those patients less than 70 years. So it means that inflammation is playing a significant role. This is systemic inflammation. And it's very likely that, potentially rather than, clonal hematopoiesis, deregulated innate intrinsic modification in cytokines driven by the virus might be inducing the hematopoietic signature. We don't know. It's just hypothetical. And we haven't looked into D-dimer. We haven't looked into fibrinogen. We haven't looked into those factors that might compound and accelerated increase risk for thrombosis. But as far as we know, based on those factors that are known, BMI and inflammatory markers like IL-6, total IL-6, they were very equivalent. Only CRP was differentially expressed in the subgroup that was older than the median for those patients aged more than 60. So obviously this is all open to, future research.
Dr. Rivero, there's a question from the audience regarding the hypothesis and your findings in the peripheral blood. The question is specifically in the younger population, did you find that this signature also applied as a prognostic factor?
Very good question, because those were one of the testing points. You remember, I don't know if I can share again a little bit that is slide, Maria, that will be fine. Is that okay?
I would think so.
So if we go back to the slides, it's taking some time to upload, but I can start the answer. Basically, we recapitulated, examined the same magnitude of modification in younger people, and we observed only an increase in the neutrophil count. I want to show you the data, and can you see it? Probably yes.
Yes.
So these are the others, right? Other population with an increase in the neutrophil count that is statistically significant. Then the same situation for lower AMC, absolute monocyte count. Remember, we suspect that in patients developing lung infiltrates, and when bronchoscopy are done, and we are able to apheresis and sequestrate those monocytes, they have a peripheral blood phenotype, and they are IL-1 skewed. So we're suspecting that these monocytes are relocated into the lung or any organ that is being damaged by the virus, and then absolute lymphocyte count low. For younger people, only neutrophil count goes up, but we don't see the same effect on monocyte and lymphocyte. So the answer is, it looked like this hematopoietic signature might be associated with life-threatening disease, but only in those patients aged more than 60. That brought, the question that we don't know if potentially bone marrow and the hematopoietic compartment might be primed by clonal hematopoiesis. We don't know. It needs to be investigated.
Dr. Davalos, I understand you had a couple of slides that you wanted to share.
I missed that opportunity, but I have somebody preparing those slides for us in the near few minutes, so I'll try to show them immediately. I just have one more question to Dr. Rivero in that particular matter, is that it's been seen that in ICU patients with severe COVID disease, a very popular misconception is that if the white blood cell count increases, showing a leukemoid reaction kind of phenomena, it's been targeted as a deterioration of its metabolic or hematological conditions, and most of them are given prophylactic broad spectrum combination of antibiotics. Interpreting or reinterpreting or redirecting the signature that you're mentioning to us, is it a safe advice to start antibiotics with an increased white blood cell count under the premises that it might be due to your signature phenomenon?
So I'm going to be answering this question along with Maria. I'm going to need your help, Maria. But I can tell you something. We compare procalcitonin, and we found that procalcitonin is not skewed toward any, it's not skewed between no life-threatening and life-threatening. So meaning it's equal. So the second point is, I do suspect that, our threshold for infection should be very low, right? Because we do see significant amount of patients, even being young, who come with bacteremia at the same time when they are diagnosed with COVID, especially those patients that we see in our chemotherapy wards. So the second piece is a virology intrinsic factor that have been recognized to increase the neutrophil count, is CXCL8, induce neutrophilia. So we really don't know if this is intrinsic to the viral intrinsic biology, or this is more like a host factor. So what we have enhanced as a prediction tool is associated with life-threatening conditions. So Maria, you have something to say about initial administration of antibiotic broad spectrum, or any differential antibiotic that should be pursued in those cases, especially for life-threatening disease?
Actually, antibacterials, I just reviewed that data, and although the initial Chinese study suggested a high rate of co-infection, most recent series have found that the bacterial co-infection is not as often, and is in new admissions is about 4%, is about 15% throughout the hospital stay, is more often in the ICU. And probably in the ICU has more to do with prolonged stay in the ICU, intubation, multiple tubes, and everything else than with COVID itself. So we propose that antibiotics should be used when a bacterial infection is suspected. And in the ICU, that's always a difficult call to make, and people have to use their best clinical judgment. But yes, we do see more bacterial complications in the ICU, and some series also have reported fungal infections, including Aspergillus. I'm sorry, but Dr. Delos, Rios had a couple of slides. So, Dr. Rios, would you want to share them now?
Okay, but I want to say something previously. These are complex patients, and maybe there are confounding factors in patients with leukocytosis or with an increase in white blood cells. No, for example, when you use esters, no? And maybe a lot of patients receive steroids, and this also can increase the white blood cells. No?
Mm-hmm.
And this is one of the factors that we must to consider when evaluating patients with increasing leukocytes.
Correct.
For example.
Yes.
That was one of the caveats that we had.
I want to say only some diapositives. This is the situation in Peru of August. We have almost 500,000 of patients with confirmed COVID and more than 20,000 dead people. No? And but in the age group more affected is the patient with age between 30 and 90 and 59 years. No? It represents 60%. No? But like in all the world, the age group with the lethality rate high is the people more than 60 years, no? With a lethality rate of 12, and this represents 8.8 times lethality rate of the other adult group. But in Peru, when the most affected persons are in the group of minor than 60 years, the obesity is obesity and age more than 60 years are the main principal risk factor. No? And this is in correlation with one of the diapositives of Dr. Rivero. No? When the younger the population, the obesity was the highest risk. No? Maybe this explain in part this sense. This is an age distribution of population in Europe, distribution of population in USA, and the Latin American population. You can see that population in Latin America is younger than population in Europe and USA, and maybe partially explain the case fatality rate is minor in Latin America than Europe. No? And maybe this partially also explains the continuous propagation of the pandemic in our countries.
Mm-hmm.
That's all.
Oh, thank you. Very interesting. Thank you so much. Any other comments on age groups that you're seeing affected in your localities? You see same phenomena, I'm assuming. Any comments, Dr. Lara?
Same phenomenon. Over here in Guadalajara, 90% of our patients are over 65. High mortality rate in those, approximate to the global numbers. We have had some young patients, and yes, obesity is notorious right now. I mean, I have never noticed a number of obese patients that you would deem unlikely to be infected otherwise. So there's something going on there also. Also, we're using metaphylaxis. This is not prophylaxis, right? Bodies sync at the and small triggers to do broad spectrum antibiotics, which is questionable because we're going to get in the same trouble as non-COVID ICU situation where we pressure pan-resistant or multi-drug resistant pathogens. And in terms of thromboprophylaxis, the same, also using higher dose or more dose dosages in most patients. And yes, we should use more unfractionated heparin in renal dysfunction patients, but we tend to start with low molecular weight heparin regardless in renal dysfunction, and just watch out, right?
Yeah. Okay. Well, thank you very much to everyone. Thank you to our panelists. Do you want, before we wrap up, Dr. Davalos, do you want to add anything else?
Yes, Maria, just one final comment in that Ecuador shares mostly the same biostatistics than Peru. And our mortality, even though we have today reached the 90,000 positive cases, reaches only 6,000 deaths as probably an invalid figure. But what I would like to stress is the fact that even though these countries are very young population in comparison with the European and some parts of the US, what we're seeing is that our ICUs, or the hospital that I'm working at right now, sees that most of the beds are staffed by people over 60 years of age, and that mortality is in the rise. And what one of the panelists was mentioning is that creating or building up a excessive pressure due to unguided usage of antibiotics is really what brings the statistics from the non-COVID area to the COVID area. And it might not be a good idea to start with that at the moment. What I wanted to ask the panel, and probably you, Maria, and Gustavo, is that it's becoming quite a popular recommendation to start with immune serum transfusion or plasma transfusion to patients which are doing really bad on the second week of intubation and ICU stay. And what is your thought about hemofiltration and removal of cytokines and debris proteins from blood in those very sick patients?
Oh, that's a novel concept.
Yeah.
I think it's being proposed. I don't think I can say much about it because I'm not really sure when it has been applied. Many patients end up being on dialysis, but that's not quite the same as ultrafiltration. So I really cannot comment on that one.
Mm-hmm.
We are using, I think you mentioned also convalescent plasma as well. Yeah, we're using convalescent plasma here as part of an expanded access program. So we're not participating in a clinical trial. At least we know from the initial data that it's safe, but really we don't know much yet about efficacy. And the one study that was published in the randomized clinical trial from China did not show efficacy. Dr. De Los Rios, you had a comment to make regarding ultrafiltration? You wanted to comment on it?
I wanted to make a comment about cytokines and the link with removing potentially. I just want to tell you that in the context of IL-6, potentially one of the pathogenic cytokines, we had data from July 28, Maria, that the Covacta trial didn't achieve primary endpoints, meaning the administration of anti-IL-6 monoclonal antibody didn't improve the survival or any other primary endpoint in the trials. So I think, especially for life-threatening condition, the overwhelming CRS cytokine release syndrome doesn't look like we are going to achieve much by providing those medication, and I would say less so by removing such a pleomorphic cytokine.
Yeah, probably should be done, the intervention should be done sooner. That's what I think the lesson is. Even with tocilizumab, those results are still pending. The study is still ongoing. But see if tocilizumab and the antagonist for IL-6 used earlier in the course of disease, if it will have an effect. Used late in the course of disease did not. Similarly with convalescent plasma, the way I see it is more of an antiviral than treating an immune modulator. So using it earlier may make more sense than using it in the later phases.
Maria, can you make some comments about remdesivir for people without renal failure? I mean,
Well, for us, it's here standard of care. So anybody that meets the criteria for remdesivir, being hypoxemia, less than 94% by pulse ox, or the need for supplemental oxygen or worsening oxygenation from the baseline, those are a formal indication for remdesivir if they have a kidney or creatinine clearance more than 30. And that it may be one of the factors that has contributed to seeing improved mortality in our patient population, in addition to knowing more on how to best manage these patients and the dexamethasone use, obviously. Well, if no more comments, I will, before we end the session, I really would like to, Baylor, St. Luke's would like to recognize and acknowledge the following entities for their support in today's program. And those are Sociedad Peruana de Medicina Interna, Sociedad Peruana de Neumonología, Universidad San Martín de Porres, Clínica San Felipe, Lima, Perú, Hospital San Javier Medical Education Department, Guadalajara, México, Instituto Nacional de Cáncer, INCAN en Mexico City, Sociedad Mexicana de Oncología, SMIO, Universidad San Francisco de Quito, en Ecuador, Neuroquito, Ecuador, Cura, Quito, Ecuador, Centro de Medicina Integral, C. Mater Dei, Tegucigalpa, Honduras, Hospital Semesa Medical Education, San Pedro Sula, Honduras, Liga Hondureña contra el Cáncer, San Pedro Sula, Honduras, Hospital Herrera, Lerrandi, Guatemala. We'd like to invite you to the 8th virtual roundtable on Friday, August 21st at 1 p.m. Houston time, Central Time. Lecture is the state-of-the-art scarless thyroid surgery by Dr. Raymond Grogan, Associate Professor at Baylor College of Medicine. And this ends our presentation for today. Thank you very much to the audience for attending the session, to our panelists, and to Dr. Rivero. And if you want to receive alerts on future events, subscribe to the St. Luke's Medical Center channel.